medicines. I also like to talk a little bit about neuroplasticity, and I'm going to end with this. Neuroplasticity is how the brain changes, how the brain reacts and changes its activity in response to our own activities and experiences. Our brain is smart. Our brain has learned to model the changes it needs to react to the situation, the environment, the activities we give it. So, neuroplasticity with Parkinson's is always often thought of as the value of, for instance, exercise. Move it or lose it, right? The more I exercise, the greater the brain changes that are associated with that exercise. And here's just a couple examples on this slide. This is a brain scan where they measured brain volume, size of the brain in a research study, in older adults, not with Parkinson's, but older adults that did two different types of exercise routine. One was high intensity, one was low intensity. And I can't remember which one is which off the top of my head right now, but the yellow and blue areas represent areas of the brain where there was increased brain volume based on the exercise. A different area with low intensity, different area of higher intensity. So the brain is actually changing its activity, changing and enhancing its function as a result of the experience, in this case, physical activity. The slide in the corner here, here's an example of individuals who injured their arm. They injured their arm and they required a cast. It needed to be set so they couldn't use it. Maybe they fractured their arm. And there is a special way you can do imaging in the brain and look at activities of motor neurons. So these are nerve cells that control movement, and we can actually track them all the way down into the spinal cord and then out into the muscle. And what you see is, you probably can't see it too well from the back, but on the left-hand side, these are the individuals, these nerve tracts look like, very robust at the time of injury, and then just a few weeks later, already decreased activity because they're not using that arm. So our brain responds to what we give it, in the positive and the not so positive. So our experience, how we move, think, believe, behave, affects our brain. And what neuroplasticity is, we have our one nerve cell interacts with another nerve cell, right? And they interact through these connections. And neuroplasticity allows these connections to sprout and expand, giving more efficient nerve connection and nerve activity. More efficient neural transmission increases or decreases brain activity and brain function. So we can change our brains. And we have to think about this with medicine as well. Once again, it's a balance. If we under-medicate, we will be changing how we move. Because medicine, with DBS, the right amount of medicine can help normalize movement. When we're normalizing movement, we're reducing the rigidity, the stiffness, the slowness, the decrease in amplitude of movement. We're reducing how our brain is responding to the Parkinson's movement. We're now responding to more normalized movement and enhancing those areas of the brain. Also, if you feel better, if you move better, you'll move more. Simple math, right? You don't feel well, not moving well, you probably won't move so much. So you'll be moving more and perhaps reinforcing those neuroplastic changes because of increased movement. If we don't have motivation, if we're depressed, if our medicines are too low and we're not treating motivation and depression, we'll see the world, we'll experience the world, and our physical activity, our mental, emotional activities will reflect that. All this reflects back into this equation called neuroplasticity. So there are many reasons to think of the value of medicines before surgery, what medicines can't do that surgery is designed to do for it, and then after surgery that there may be a role, and for every individual it's a different amount and with different goals for which medicines and how much medicines and what we expect those medicines can do. There was a lot in one talk. I leave you with a few other resources, and I'm going to pass out some cards. So Sierra and I like to do a lot of education, or Sierra Ferris, I'm sorry, is in the back, our DBS programmer. We have 2 websites. An area of interest of mine, in addition to neurology and movement disorders, is integrative medicine and holistic health. So I do run a blog on holistic brain health, and Sierra runs a blog, dbsprogramming.com, on DBS and DBS management. We also have a DBS clinic at our center, and we're in the process, we're very excited to announce a new DBS physical therapy program, which is starting up next week. I also want you to tune into DBS University, where we will have DBS 101 and 201. 101 is for people who have not had DBS and want to learn a little bit more, or their family members. And 201 is for people living with DBS, so in a more intimate setting to go through the anatomy, the physiology, what the expectations of programming and stimulation, long-term consequences of medications and the disease and so on. And that will be happening throughout the year. And the first one is in Boulder in April, followed by Colorado Springs, Fort Collins, and here in Denver. So we don't have flyers on that, but that will be at our website. And then, let's see, what else do we have? We have, I think, 10 books. So we thought it would be fun to give away some of these books to you all. So maybe, Sarah, you could help me pass one out to each table. So DBS, a patient-guided deep brain stimulation. We'll pass one out to each table. And then the job of each table is, the contest is to come up with the number of years that DBS has been studied for movement disorders. Take a guess. And so you're going to come up with that number. Whoever is closest to the number at your table gets that book. We'll give you a few minutes with that. So how many years it's been actively, intentionally studied for movement disorders? Not FDA approved.
17.
Well, you have to, the group is going to come up with whoever at the table is closest.
I know at least 20.
Oh, you didn't run out of books?
Which table does not have, okay, this would be good to claim your book at the center. So I'll leave. Or I can buy a table. Oh, okay. I'll, this is good for a book?
Okay, I hear some mumbling, maybe some rumbling.